Welcome back to the Radiology Advances podcast. Today we're looking at a study that takes a fresh angle on an old problem. How do we reliably flag cardiomegaly when it shows up incidentally on a chest CT that wasn't ordered for the heart at all?
The paper is Artificial Intelligence-Enabled Cardiac Volumetry for Opportunistic Screening of Cardiomegaly on Chest CT, Clinical Validation with Echocardiography, published in Radiology Advances in 2026. It's by Christopher Fan, Angelo Scanio, Fernando K., and colleagues. The work originated at the University of Texas Southwestern Medical Center in Dallas, with corresponding author Dr. K. now at the University of Texas MD Anderson Cancer Center in Houston, in the United States.
And the clinical motivation is pretty stark. Chest CT is the third most common CT exam, and a huge fraction of those scans are ordered for non-cardiac indications. Pulmonary embolism rule-out, lung nodule follow-up, trauma. But the heart is right there in the field of view.
Yeah, and cardiomegaly affects almost 6 million Americans. It's associated with heart failure, arrhythmia, myocardial infarction, and sudden cardiac death. So the opportunity cost of not catching it on scans that already contain the information is high.
Right, but the problem is that on a non-ECG gated, non-contrast chest CT, qualitative cardiomegaly reporting is really variable between radiologists. It's based on the gestalt of the heart looks big, which is not a very precise instrument.
Especially in borderline cases. You can do manual linear or volumetric measurements, but that's time-consuming and it's not practical for an incidental finding on a busy list. So there's a real case for automation.
And this study tests one specific FDA-cleared automation, Siemens Healthineers AI Rad Companion, which puts out a total cardiac volume measurement, TCV-AI, directly from the non-contrast, non-gated chest CT.
The study design is retrospective. They enrolled 307 consecutive patients at UT Southwestern who had a non-contrast, non-ECG-gated chest CT, plus a clinically indicated echocardiogram within 31 days of each other. Median age, 67, 56% male.
Why a 31-day window?
To ensure the cardiac state was comparable between the two modalities. And notably, the median interval was only 2 days. Most of these were paired very closely in time. Sensitivity analyses restricted to intervals under 7 days and under 15 days showed essentially the same diagnostic performance, so that temporal gap wasn't driving the results.
And the CTs weren't from a single vendor, which matters for real-world generalizability.
7 scanner types across 4 vendors: Philips, Siemens, GE, and Toshiba. Philips made up about 40% of the cohort, Siemens 30, GE 26, Toshiba about 4. That heterogeneity matters because AI tools often underperform when deployed on hardware different from what they were developed on.
Now, the reference standard is echocardiography. What exactly were they comparing against?
Board-certified cardiologist reads of transthoracic or transesophageal echo extracted from the finalized clinical reports. They defined cardiomegaly as any chamber dilation, right atrium, right ventricle, or left ventricular hypertrophy. Each finding was graded ordinally: 0 for absent, 1 for mild, 2 for moderate, 3 for severe.
And what did the echo reveal about the cohort?
About 49% of patients had no chamber dilation or LVH at all. The left atrium was the most commonly dilated chamber at 32.2%. Then the right ventricle at 18.5%, the right atrium at 16.6%, and the left ventricle at just 6.2%. Left ventricular hypertrophy showed up in about 20%.
Okay, let's get to the core comparison. Does TCV-AI, the automated cardiac volume, discriminate between normal and abnormal echocardiograms?
It does. Median TCV-AI was 1,061.9 milliliters in patients with any echocardiographic abnormality versus 798.4 milliliters in those with a fully normal echo. P less than 0.001.
That's a clean separation. But cardiac volume scales with body size, so a raw number isn't directly comparable across patients.
Right, which is why they indexed TCV-AI to body surface area, TCV-AI over BSA. And because male and female cardiac volumes differ systematically, the median was 1,013 milliliters in men versus 795 in women. They stratified the diagnostic analysis by sex.
And the ROC results?
Area under the curve was 0.81 for men, with a 95% confidence interval of 0.75 to 0.87, and 0.77 for women, confidence interval 0.69 to 0.85. So, fair to good performance by the standard framing.
Tell us about the chamber-specific analysis. Because if you're going to claim this biomarker reflects meaningful structural disease, it should correlate with the underlying abnormalities, not just with some generic heart looks big signal.
Exactly what they tested. Ordinal logistic regression showed that TCV-AI over BSA was significantly associated with the severity of left atrial dilation, left ventricular dilation, left ventricular hypertrophy, right atrial dilation, and right ventricular dilation on univariate analysis. But when they built a multivariable model, adjusting each chamber's severity for the presence of other concurrent abnormalities, the association held for every chamber except one, right ventricular dilation.
Why did the RV drop out?
This is one of the more interesting threads in the paper. Unlike the left ventricle, there's no well-established geometric model for quantifying RV size on two-dimensional echo. RV size is notoriously underestimated on echo compared to cardiac MRI. And because the study relied almost entirely on transthoracic echo, 301 of the 307 patients, the RV reference standard itself may have been noisy.
So the univariate RV association might have been a confounded proxy for other concurrent chamber dilations.
That's their read. Once the model adjusted for concurrent LV, LA, and RA abnormalities, the independent RV signal fell away. It's a caveat for clinical interpretation. TCV-AI is not an RV-specific biomarker.
Let's talk cutoffs, because this is where the paper gets practically useful. What are the operating points?
Using Udin's method for the balanced optimum, the best cutoff was TCV-AI over BSA above 500 milliliters per square meter in men and above 471 in women. For men at that threshold, sensitivity was 76%, specificity 79%, accuracy 77%. For women, sensitivity 68%, specificity 79%, accuracy 72%.
But the authors emphasize that with a continuous biomarker, you don't have to pick one operating point.
That's the real selling point. You can tune the threshold to the clinical task. The authors selected a high sensitivity threshold, 386 for men and 362 for women, calibrated to yield about 95% sensitivity in the derivation data, useful for triage. And a high specificity threshold, 584 for men and 557 for women, calibrated to yield about 95% specificity, closer to a confirmatory call.
Now, they tested those pre-specified thresholds in an independent validation cohort, another 50 patients collected later, outside the derivation window. How did the thresholds hold up?
The high sensitivity threshold gave 89.3% sensitivity and 27.3% specificity. The balanced Udin threshold gave 60.7% sensitivity and 72.7% specificity. The high specificity threshold gave 28.6% sensitivity and 100% specificity.
Some attenuation from the derivation cohort, as expected. But here's the really interesting comparison. They also went back and looked at the original radiology reports for the same validation cohort patients. What did the radiologists themselves pick up?
The radiologist reported cardiomegaly showed sensitivity of 21.4%, specificity 95.5%, PPV 85.7%, NPV 48.8%, and accuracy 54%.
So when a radiologist calls cardiomegaly on a non-gated chest CT, they're right about 86% of the time, high specificity. But they're only catching 1 in 5 true cases, very low sensitivity.
Which is consistent with how cardiomegaly is reported in practice. It's a conservative, qualitative call. Radiologists flag it when it's obviously big. The AI biomarker lets you pick an operating point that fits the task, a sensitive screen, a specific confirmation, or a balance.
And the repeatability question. Because if the measurement bounces around from scan to scan, it's not going to be useful longitudinally.
That was tested in a separate cohort of 248 patients who had a total of 544 repeat chest CTs, with a median interval of 61 days. The intraclass correlation coefficient was 0.93, 95% confidence interval 0.91 to 0.94, which is excellent by the standard thresholds. Bland Altman analysis showed a mean bias of negative zero point 0.8 milliliters between repeat measurements, with 95% limits of agreement from minus 200 to plus 199 milliliters.
Excellent reliability. So the measurement is stable when the heart is stable.
Which is what you'd need if you were going to track cardiomegaly longitudinally in a patient getting serial chest CTs for something like lung nodule surveillance.
Let's talk about where this doesn't generalize yet, because the limitation section is substantial.
It is, first, single center, retrospective. Second, and this is the important one, inclusion required a clinically indicated echo, which means the cohort is enriched for cardiovascular disease. 92% of the derivation cohort had a history of CV disease. That's very different from an asymptomatic screening population.
Meaning the PPVs and NPVs are inflated by high disease prevalence.
Exactly. If you applied this to a general screening population with much lower cardiomegaly prevalence, the positive predictive values would drop substantially. Establishing normative reference ranges in asymptomatic patients, people getting both CT and echo without clinical suspicion, is an important future direction.
There's also the point you raised about echo itself being an imperfect reference, especially for the right ventricle.
Right. And they also couldn't visually review or manually correct the segmentations produced by AI RAD Companion. In their institutional deployment, only the numeric outputs are surfaced. So subtle segmentation failures due to motion artifact or unusual anatomy couldn't be adjudicated.
So to put it all together, what's the takeaway for clinical practice?
Automated cardiac volumetry on non-gated, non-contrast chest CT is a reproducible, threshold tunable biomarker that substantially outperforms qualitative radiologist reporting on sensitivity in this cohort. It's not a replacement for echocardiography, but it's a viable, opportunistic screening layer on top of CTs that are already being done for other reasons.
And it fits into a workflow that already exists without adding radiologist time.
Which is the whole point of opportunistic screening. The data are already there. The question is just whether you extract them.
Thanks for joining us. We're coming to a close of today's Radiology Advances podcast. Thanks to Fan and colleagues for their work published in Radiology Advances. If you found this episode informative or have any other feedback, please rate, review, and subscribe. It helps more people discover the podcast and supports the broader conversation around innovation in imaging. You can read the full article and explore more great content on the journal website. This episode was generated with the help of AI, but all content was reviewed and verified by editor Dr. Luca Solhofer from University Hospital Essen in Germany for accuracy. Thanks for joining us.